Good afternoon, everyone, and welcome to the first edition of Invitation to a Conversation. I hope everyone had a blessed holiday and looking forward to a prosperous new year. The first I want to say this in lieu of Vice President Kamala Harris not winning the presidency this year, my conversations is all in the year of the woman. And so to kick it off, I have Dr. Kateena Addae, my niece. Hi, Dr. Tina. How you doing?
Hi, Auntie Pam, and hi, everybody. It is such a pleasure to be here this afternoon.
Thank you for taking the time out. I know you're a busy doctor, but thank you for taking the time out. I like to use this platform to educate people who need whatever we have to showcase and give what information we have to give them to educate. And so today it's all about women's health and what you specialize in. So first, can you tell everybody who Dr. Tina Adu Kanede is?
Yeah. So my maiden name is Kateena Johnson. So I'm from Brunswick, Georgia. Born and raised by my grandparents, Evelyn and Lawrence Lemon, and my biological parents are Charlie and Beverly Lemon, Charlie Johnson, who are both in my life and active. I am a maternal fetal medicine doctor. So what does that mean? That means that I went to medical school and then I did a 4-year residency in obstetrics and gynecology. And so I'm a board certified OBGYN, but then I went back and did 3 years of fellowship immediately after completing residency in maternal fetal medicine. And so that is a subspecialty of obstetrics and gynecology that focuses on high risk pregnancies. So I take care of the sickest of sick moms.
Mm,
um,
mm.
and moms that when they become too sick and they risk out of general OBGYN care, I am the doctor that takes care of them. So if a woman has a lot of comorbidities or her baby has an unexpected problem or she's admitted to the hospital for any reason or she's in the ICU for any reason, I am the doctor that takes care of those patients.
Thank you. And let them know that your granddad is the man that ran the skating rink.
Yes, my grandfather is preacher. He's the cowboy
Mhm.
preacher.
Yes. So, Dr. Tina, how did you choose this profession?
That's a great
What influenced you?
That's a
Hmm.
great question. I remember I think I was about 12 or so, and my grandmother had some people over the house, and somebody asked me, "What do you want to do when you grow up?" And I said, "I wanted to be an archaeologist." And my grandmother said, "No, no, no, you're going to be a doctor." And I was like, "Oh,
Mm.
that's okay. Well, let me kind of look into this." And so, um, in high school, I started thinking about taking care of women. I really liked helping people and specifically like helping women. So I started kind of thinking about OBGYN. But it didn't really, I didn't solidify my decision, I think, until I was in college and I won this scholarship to go anywhere in the world I wanted to go to do humanitarian service. And the scholarship would pay for it. And so I decided to go to Tanzania, which is a country in East Africa. At the time, I think I was maybe like 19 or
Mm.
20 years old. And so I spent the summer working with the Maasai tribe in Arusha, Tanzania. And at that time, HIV was devastating. It was just ransacking the country. There were a lot of HIV positive families. The Maasai community was affected heavily by that. And I came across a lot of women who were like HIV positive, who was just struggling with their health and taking care of their children and their families. And from that point, I knew it was kind of just set in stone for me that I was going to embark on a career of helping women.
That is excellent. So, how is that country of Tanzania? How did they receive you going over there? Just a little bit of at 19 years old, were you starstruck? How was that initial reaction?
I think the one thing that was kind of like mind blowing to me, before that, only other country I traveled to before was Greece. I had went to Greece like maybe a month prior to that before I went to Tanzania. So it was when I got off the plane and I just saw a sea of black faces at
Mm,
19 years old. It was just like, wow, I was just amazed that I was in this country just full of people that looked like me.
mm,
And clearly I didn't look Tanzanian, so people knew that I was not from the country, but they
mm-hmm,
were really accepting and caring and friendly, and it was really a great experience. And I think, going through that taught me a lot. I really learned the difference between wants and needs.
mm,
Remember coming home and my grandmother was like, "Who is this child?" Like she would ask me for something. I was like, "No, I don't need it. It's just
mm-hmm,
a want." Because I saw so many the that gaps between the have and the have nots is just extraordinary.
mm-hmm,
In that country, here in the U.S., we do have some safety nets, but there was no safety net. So if you didn't have anything, you just didn't have anything.
mm,
And when I left, I remember leaving all my clothes to this family that had several daughters because I would see the kids just run around and barely little of nothing because the family just didn't have anything.
mm. That's awesome, awesome. So before we get into the meat of your profession, there's a couple of words that I want to be defined so everybody will understand. So can you explain clinical research and what type of research you do?
Yeah, so I don't do research anymore, but I did. And so when I went to Morehouse School of Medicine, well, let me take a step back. So I always encourage every young person when you're in college, every single summer you should be doing something. You
Mm-hmm.
should not go back home. You should spend those summers exploring the world. Um,
Mm,
you have the World Wide Web at your fingertips to look for scholarships, to look for fellowships, all kinds of things that you can do that will financially support you to broaden your horizon. And so, with that said, it kind of segue back to Tanzania. After that experience from HIV from a community perspective, I wanted to learn more about HIV from a science perspective.
mm,
From that experience, I was like, there is only so much I can do as one individual as far as treating a community. But if I became a scientist or did research, I can touch lives that I will never encounter just
mm,
by discovery. And so I came back and I applied for NIH. I think it was a T fellowship or grant, T21 fellowship or something like that. I can't remember. It was so long ago. And I got it. And so the next summer I spent working at NIH, doing HIV/AIDS research on the bench. So doing basic science research in a lab that was fully paid for, including a stipend. And so in that lab, the PI, which is an acronym for principal investigators, the person that led the lab, noticed something in me. She was like, "You have a talent on the bench. These things just are coming so naturally to you." She actually discouraged me from getting an MD and told me I would be wasting my time doing clinical medicine and that I was better suited to do research because I was
mm,
naturally talented and good at it. And so she encouraged me to pursue a PhD. But at the time, I was like, I don't know. I really do like working with people. And so when I just applied to medical school. And so I got accepted into a couple of medical schools, but decided to go to Morehouse School of Medicine. I thought it was the best fit. And as luck has it, my mentor was actually an HIV/AIDS researcher at Morehouse School of Medicine. So he was the department chair for microbiology, biochemistry, immunology, but also was a PI of a basic science lab that did research on HIV. And so that summer, he allowed me to come to his lab, do research, and paid me to do the research. And he also said, "You have a gift, like you should keep this up." And so he encouraged me to apply for the PhD program. And so I ended up doing 2 years of med school, came out, did the PhD. And so that
Mm,
was about 4 to 5 years PhD, basic science on the bench, which was completely paid for by Morehouse School of Medicine. And then I went back and did the last 2 years of medical school to complete
mm.
the MD. So I have both an MD and a PhD.
So I have a two-part question. What is one of the things you found out about the HIV research that the everyday people don't know? And
Yeah,
how
so
and how is people living with HIV longer nowadays? It's not a death sentence anymore.
Yeah, so HIV is an example of the power of basic science research. It really is, and not only is it an example of the power of basic research, it is also an example of the power of the voice of the people. So Anthony Fauci um,
Hmm.
is phenomenal. You know, despite what happened with COVID and all
Hmm.
of hoopla. He is a phenomenal physician and scientist. He's also has an MD, PhD, and as a leader of one of the institutes at NIH, so the Infectious Disease Institute at NIH. And so he was instrumental in discovering the antiretroviral therapy that has saved so many lives. And so it wasn't until antiretroviral therapy came out that we started to see HIV become a chronic disease and not a death sentence. And that was in the 90s. And so with the initial studies that came out with antiretroviral therapy, they were seeing such promising data. But typically it takes a little bit longer time as you go through the clinical trials to get that drug out to the market and FDA approved. But the public got a hold of how phenomenal and fascinating the data was in the clinical trials that they really protested and pushed for those drugs to be rapidly expedited to the market. And
Mm.
so because of that, a lot of steps got skipped, and the drug went to the market faster than what would really happen in research and development because of the voice of the people. And because of that, in the 90s, it revolutionized the disease.
Mm. What is biomedical science?
Biomedical science is essentially the study of medicine and how it can impact and change lives, essentially.
Okay. And you said you have a love for the maternal fetal, which is the acronym is MFM medicine. And why do you have a love for that? Explain that.
Yeah, so I'm a maternal fetal medicine doctor. And so essentially what that is we take care of sick moms and sick babies. Not sick babies, I would say more so babies where in utero we discover an issue. And then we follow those babies over time. And so I not only take care of moms from a clinical perspective, I also read ultrasound. So typically, like when you come in as a high risk person and you get an ultrasound, I am that doctor that's trained to read that ultrasound to discover any type of anomalies for the baby. And then if we discover an anomaly for the baby, then we talk about management during the pregnancy. And then we get the appropriate subspecialist after delivery to get involved to take care of the baby. So that's essentially what I do. And as that love kind of stemmed from residency. So when I started residency as general OBGYN, I wasn't quite sure what I wanted to do. I knew I wanted to do some type of fellowship, but I knew what the fellowship would be. But and so we have to rotate through the major subspecialties of OBGYN. So you rotate through maternal fetal medicine, which is what I do. You rotate through reproductive endocrinology and fertility. Those are the doctors who get people pregnant. So IVF. You rotate
Okay.
urogynecology, which are the people that take care of women later in life that develop urinary incontinence, fecal incontinence. They're the ones that do those surgeries. And then you rotate through gynecological oncology. And so that is the area of OBGYN for women who have reproductive cancers, like uterine cancers, ovarian cancers, those doctors surgically and medically treat those women. And
Mm,
so I rotated through all of that, and maternal fetal medicine just kind of really stuck with me, which kind of made sense because initially I was going to I wanted to do internal medicine, and then decided not enough procedures. I like to operate, and so maternal fetal medicine was kind of that great blend because I can still operate and it's still very medicine heavy. And so
okay.
the women I take care of, they usually have hypertension,
Mm,
a couple of medications, they have diabetes. I'm managing their so when a woman has diabetes in pregnancy, I manage their insulin. So I'm managing
mhm,
their insulin. If they have high blood pressure disease in pregnancy, I'm managing the antihypertensives. I have some women that have lupus. I have women that have cancer. I've treated women who were pregnant who had breast cancer. Uh,
mm.
and so I love that complexity of maternal fetal
You
medicine.
like that challenge.
I
So
like that challenge.
when women are pregnant and they have diabetes, does that mean after pregnancy, sometimes down the road they're going to be diabetics?
That's a great question. So you have pre-gestational diabetes and gestational diabetes. So pre-gestational diabetes is women who have type 1 or type 2 diabetes that get pregnant. So I take care of those patients as well. But obviously, after they have the baby, they're still going to have their diabetes, right? Um, and then there is gestational diabetes. So these are people that develop diabetes during pregnancy that's only related to pregnancy. And then
Mm,
as soon as they deliver and the placenta comes out, then they no longer have diabetes. But it's really important to know. So, like if I have someone who develops diabetes in pregnancy because of their placenta, women who often develop diabetes in pregnancy typically have some underlying genetic predisposition to it. And so oftentimes when you ask them, do you have family history of diabetes? They say, yeah, my mom had diabetes, my grandmother had diabetes, somebody in my family had diabetes. And so those women are at higher risk of getting diabetes in pregnancy. Also, women who have comorbidities, so women who are older, women who are obese, they have a higher chance. And so I tell them, you develop diabetes in pregnancy, there is a very high chance. Like pregnancy is kind of a window into what your future could look like. So women who develop high blood pressure disease in pregnancy, like preeclampsia, gestational hypertension, or diabetes in pregnancy, have a very high risk of developing those conditions later on in life. And so pregnancy gives us the opportune time when women are most motivated to make lifestyle changes, to make those changes during their pregnancy and to continue those changes throughout their life, whether
mm,
that's exercise or diet, changes in
mm.
diet.
And while you were saying that, something came across my spirit. How what is the effect of a child born with the biblical cord around their neck? Are there any future prognosis after as they get older?
No. So sometimes that happens during labor. So when someone is laboring, the umbilical cord can sometimes get wrapped around the baby's neck. Now, sometimes, like when we do continuous fetal monitoring, so we put you on the monitor, we're monitoring the baby's heartbeat during labor. Oftentimes, that will show up in the heartbeat. And so we start to see changes in the heartbeat. And if the baby's not recovering from that, then that will be indication for cesarean delivery. And
Okay.
so we will oftentimes find it, because we urgently rush back for C-section because we see fetal distress, and that could be because the cord is wrapped around the body or the neck, and
Okay.
that affects the perfusion of oxygen and blood to the baby, and that's why we see the heart rate changes.
Okay. What is prenatal diagnosis?
Prenatal diagnosis is diagnosing someone with a condition during pregnancy, essentially. So, sometimes I'll have moms that they come in for an ultrasound and their baby has an anomaly, like the heart is abnormal, or there's abnormalities with the bone structure, things like that. And so that's a prenatal diagnosis.
Okay. You said you like helping pregnant individuals navigate the complexities of their high risk pregnancy. So you like a challenge. So you bet, yeah. So what does that look like? Now, you might have explained that in your previous answers or whatever, but can you give us a small example and how you navigate that?
Yeah, so sometimes, some moms can have a really complex pregnancy. One example that's kind of dear to my heart is I was taking care of a patient that had breast cancer. So she has a family history of breast cancer. And when she got pregnant, she was complaining to her midwife that I feel this lump in my breast. And so the midwife astutely got a breast ultrasound and they found the mass. And then they did a needle biopsy of the mass and it came back as malignant. And so that patient was then immediately referred to me to manage throughout the pregnancy. And so obviously this is very scary for her. She's pregnant, she has breast cancer now. And so essentially my job was to one, monitor her baby, monitor her, but also work very closely with her medical oncologist. And so typically for those patients that have breast cancer, we start chemotherapy in the second trimester. We do not delay it
Mm.
because that can affect mom's prognosis. And we start the chemotherapy in the second trimester instead of the first trimester, because in the first trimester, all of the organs are developing. So embryogenesis is happening. So the heart, the brain, the lungs, all that is developing. So we don't want to introduce any type of toxic agent in that situation. Um,
Mm-hmm.
so once we get past embryogenesis, which is usually, once we enter the second trimester, which is like 14 weeks and above, for moms with breast cancer, we start talking about chemotherapy. And so we start chemotherapy with the medical oncologist, but the chemotherapy can increase the risk of growth restriction for the baby. And so we have to monitor the growth of the baby like every month throughout the pregnancy. And then typically we will stop the chemotherapy about a couple of weeks before delivery. We time the delivery. We stop the chemotherapy because chemotherapy can cause bone marrow suppression, increase the risk of infection for both mom and baby. So we stop the chemotherapy, we plan the delivery. And then once the baby's delivered, the mom either goes back to chemotherapy or she gets some type of surgery if needed.
Okay. Which trimester during pregnancy that needs the most attention?
Um, that's a good question. I would say really all of them.
All of, I
Um,
know, I asked that question because things have changed over the years since I've had my children. And so they used to say around the 5 or 6 months is more serious than, so I was saying, has any of that changed?
so first trimester is actually very important when a lot of women don't know that they're pregnant because that's when, embryogenesis is happening. And so if you're smoking or you're drinking or doing any um, uh, recreational drugs, that can affect the way your baby develops. And also to women who have comorbidities going into a pregnancy. If your diabetes is poorly controlled, if your hypertension is poorly controlled and you're in your first trimester, that can affect the way your baby grows. So that's really important. But the third trimester, which is, let me see if I can correlate that in months, that would probably be like 6 months of the third trimester. So 28 weeks and above is also critical because that's when we see things pop up. So that's when we see preeclampsia pop up. That's when we see growth restriction pop up. That's when we see diabetes pop up. So it's really important that you're following closely with your obstetrician or your midwife because those things will change the way that we manage you because your risk will change in pregnancy.
Mm-hmm.
And now we're starting to talk more about the fourth trimester, which is postpartum. And so
Mm-hmm.
don't realize that once you are delivered, it doesn't stop. So, that 6 weeks after delivery is also critical because we also see preeclampsia pop up then. We also see pulmonary embolism pop up then. And so a great example of that is Serena Williams. So she developed her pulmonary embolism postpartum. And so it's still important that you stay aware of your body and know risk factors or red flags, I should say, rather, in that fourth trimester too, because that can also save lives.
What is your practical philosophy for what you do.
Yeah. My practical philosophy is keeping the patient at the center of the circle. That is what's most important to me. Making sure that, as a healthcare team, we're communicating effectively with patients. I think as a doctor, it's easy to get wrapped up in our jargon, and we say a lot of medical acronyms and a lot of things that go over people's heads. So, like, making sure that someone understands what's going on in their body and what the plan is to treat whatever's going on in their body, and that we're making decisions together as a team. Um, I would say that that's probably the biggest thing.
Okay.
And listening to your patients, because oftentimes patients will tell you what they have by what they describe. And so you have to just listen.
Okay. Why is maternal birth rate so high among Black women?
High or you mean like, what do you mean by high?
Okay. The death rate.
Oh, morbidity, mortality. Oh,
Yeah.
maternal morbidity,
That's
mortality.
my yes.
Okay.
Mhm.
So I do have a couple of statistics for you. I thought that would be helpful for your audience.
Okay.
You know, um, in the U.S., that we know that there's an increase in pregnancy-related deaths over the past 30 years. And I think that's what you're hinting at. And so when we look at industrialized countries, when we look at other countries in the world, the U.S., interestingly, right, is ranked the worst in pregnancy-related deaths, which is insane because we're supposed to be this
Rich country,
this rich,
developed. Hmm.
developed rich country. And
Hmm.
so when we break that down and we look at the US, and we in the US we look at Black women specifically, Black women are at a 3 to 4 times higher rate than white women of dying in childbirth, right?
Why?
Then when we break that down and we actually go to Georgia, Georgia ranks 49 out of 50 states, only second to Louisiana with the highest death rate, maternal mortality rate. So
Hmm.
in Georgia, there is some data looking at the years of 2018 to 2020. We look at Black women were 2.1 times more likely to die from pregnancy-related causes than white women, and 70 to 80% of those deaths were preventable, which is mind-boggling. And so when we break that down and we look at what the causes are, so the most common causes of death were hypertensive disease in pregnancy. So preeclampsia, gestational hypertension. It's really important that your providers talk to you about what those red flags look like, because a lot of women don't know what they are, and they miss them. Postpartum cardiomyopathy, and so that's when the heart is not pumping effectively, and bleeding, obstetrical hemorrhage, and blood clots, like pulmonary embolisms.
So, does it have anything to do with the environment of where we live in these cities because of the birth rate? Is that any correlation?
So yeah, so why is it happening to Black women? I think that's kind of what
Hmm.
you're getting at. So unfortunately, there are many reasons why we see that, and so one of the major reasons is access to adequate health care. And
Mm.
so that could be lack of insurance, so not being insured and being able to get in to see an obstetrician regularly throughout your pregnancy. Financial barriers, like sometimes, I remember in training, women had issues of taking time off their job. Like they have several kids at home that they have to feed. And so I can't be taking time off my job to go to prenatal appointments. I got to make money to take care of my family. Um,
Hmm.
and social economic status.
Hmm.
There's also, second point is systemic issues, including systemic racism.
Hmm.
Um, and that, encompasses transportation, like being able to get to the doctor, healthy
Hmm.
food. You know,
Hmm.
food is medicine. And
Hmm.
so if you don't have good food, I think who put it? Steve Jobs says, if you don't eat your food as medicine, you will eat medicine as food.
Mm.
And that's such a powerful statement and really stuck with me. The ability to exercise. So
Hmm.
going into pregnancy with a healthy BMI, you're going to have better outcomes than someone with a BMI greater than 30. A third point is providers who listen and advocate for patients, right?
Hmm.
So you have to have someone that's going to, you call and you say, hey, I have a hard time breathing,
Hmm.
right? And you're just immediately delivered or you're pregnant. That should
Hmm.
not, no one should blow that off. They should tell you, go to your doctor or go to the hospital to be evaluated. That
Mm-hmm.
prime example of that is Serena Williams. So even with all of her money, she
Mm-hmm.
said, I cannot breathe. And she had to advocate and fight for herself to get the scan to detect
Mm-hmm.
the PE that she had to get the proper treatment.
Mm.
Late starts of prenatal care. So women not coming to care until second, third trimester.
Mm-hmm.
Um, Inability to advocate for yourself and distrust of the medical system. And
Mm-hmm.
so I can't tell you how many times, like sometimes I take care of a woman of color. I am a woman of color myself.
Mm-hmm.
Tell you something. I'm not telling you because I get paid more. I'm salaried. So no matter how long I work or how often I come, that does not change for me. So when I'm
Right.
telling you data that is evidence based, it is not because I'm benefiting from it. It's because I'm trying to help you. But
Mm-hmm.
because of the experience that Black women or Black individuals in general have with the healthcare system, there's a lot of distrust. And so
Mm-hmm.
oftentimes we're battling and fighting against that just to give people the proper care that they need.
Mm-hmm. Why is it so many cases of autism now? This was something that was very unknown in years ago, but now there is a high number of children being born with autism. And what's the
So
cause of
I can't speak to that because I'm not a pediatrician. I'm
it? Okay.
an OBGYN. I take care of women. So I don't even want to broach that topic because I don't have a stake in that and don't know the research.
Okay. Thank you for that. How has the method of delivery changed over the years?
Um, I wouldn't say so. You had a question that you had posed about cesarean delivery.
Yes.
Um, you know, the major route of delivery is still vaginal delivery. 70% of women in this country are giving birth via vaginal delivery, right? Only about 30% of cases are delivered via cesarean delivery.
Mm-hmm.
And so typically when and even that's too high, right? So the World Health Organization recommends, or WHO recommends that countries keep a C-section rate below 10 to 15% for optimal outcomes. And so in the US, we are failing because about 30% of deliveries are via cesarean section. So why is that? I think it's a couple reasons. It's multifactorial. So first of all, as a maternal fetal medicine doctor, I don't deliver anymore. I used to deliver. Um, I we always want a vaginal delivery, right? That is the best thing for mom. That is the best thing for baby. No obstetrician wants to section you. That's not, I can't speak for everyone, but that was never what the goal is. We never
Okay.
walking into a room wanting to section someone. There has to be a reason. And so there are a couple reasons why we would do a C-section. One, your cervix stops dilating for some reason, right? That would be an indication for C-section. The baby's not tolerating labor, so we're seeing signs of distress on the fetal monitoring. That would be an indication for C-section. Now, before we even go to that, we're trying everything to try to get that baby to recover, whether that is flipping mom from side to side, whether that is giving oxygen, whether that's giving fluid boluses, whether that's giving medication to stop the contractions so the baby has time to recover. We're doing all of that before urgently rushing back for C-section. Or you get to the point and you're pushing and you can't push the baby out in a certain time frame. So usually that's about 4 hours. You can't push the baby out. That tells us that there's something wrong with your pelvis.
Mm-hmm.
It's not coming out by that time. It is not going to come out. We need a C-section. So why are the C-section rates higher? I think it's a couple of reasons. I think the introduction of fetal monitoring. And so doing continuous fetal monitoring, when we see signs of distress, we're going to act on that because it is a very litigious society. And so if something happens to the baby, the obstetrician is going to get blamed. And so
Mm-hmm.
if we see any signs of distress, they're going to intervene because they're like, we don't want to take the risk of something happening to this child. Patients are sicker and older, right? So women are waiting much later in life to get pregnant because they
Mm-hmm.
want to like establish their careers, they want to be financially in a better place or stable before they have children. And so I always kind of say is pregnancy is for the young. Like we're meant to give birth in our 20s, right?
Yeah, right.
Your late
So,
teens, your early 20s. And so women in their 30s, especially after 35 years old, is going to have a much higher riskier pregnancy,
Mm-hmm.
with an increased risk of C-section. Women are coming in pregnancy bigger. So BMIs are much higher now than they were in the
Mm-hmm.
past. Women are, and because of that, we're coming in with comorbidities. So women are coming in with hypertension, they're coming in with diabetes,
Mm-hmm.
they're coming in with lupus. All of those things, because that affects the way that you labor, right?
Mm-hmm.
That, those things can be associated with labor dysfunction, um, can increase the risk of C-section. So I think, it's multifactorial.
So, and so once your woman has a C-section, does that mean that if she has more children, that she has to get C-sections?
That's a great question. So, back in the day, there used to be this philosophy of once a C-section, always a C-section. Um,
Yes.
that has drastically changed. And so, as the C-section rates became higher, there has been a national push to reduce the rate of C-sections. And a lot of hospitals have policies to reduce that rate. And one of those things that we have done as a field is, there's been a greater number of child labors after C-section. So
Mm-hmm.
if you have a C-section, it depends on the type of C-section. So there are two types of C-sections we do. One is a classical, so that's a vertical incision up and down on the uterus. Now, it doesn't matter what the incision looks like on your belly. What we're talking about is the incision on the actual uterus itself, which you can't see. So your doctor
Mm-hmm.
has to tell you that. So the vertical incision or the classical incision, that type of C-section will always have to have C-sections, because when we do that type of C-section, we are cutting into the thick layer, muscle wall of the uterus. And so that affects the integrity of the muscle wall of the uterus. So there's a greater risk of that old incision open up when you're laboring. And so because of that, you always have to have C-sections. Now we try to avoid classical C-sections at all costs. So usually there is a reason why we have to do it.
So
Now, most of the
what's
time,
the name?
no, the most of the time we do a lower transverse C-section. So that's the
What?
C-section where the incision is at the bottom of the uterus. Now that type of incision, we're not cutting into the thick muscle layer, so you can try for vaginal delivery after that. Now,
And
once you get up to 2 to 3 C-sections, most providers are not going to feel comfortable with that because the risk of uterine rupture starts to increase.
okay, so the lower one that you said, the lower, is that the one they used to call the bikini cut?
So again, that's the incision on your belly. So the bikini cut
Okay.
is what you see on your belly. But what is important to me as an obstetrician is the incision on your uterus that you cannot see. So your
Okay.
doctor has to tell you that. So majority of the time, 99% of the time, the type of incision you're going to have is that low transverse C-section.
Hmm. Hmm. We're seeing a lot more young females having children. What is the best way to stay healthy during their pregnancy?
Yeah. So a couple things. One, plan for your pregnancy if you can, because then when you're pregnant, and that's going to help you reduce a lot of risk. But I would say the first thing is know your risk. So discuss with your relatives any pregnancy problems that they experience, because some pregnancy complications do run in families, and so this will give you like some valuable clues to your own risk. So if your mom had preeclampsia or your mom had preterm delivery, there's probably a high chance that can happen to you too. Or if your mom had diabetes in pregnancy, there's a high chance that can happen to you too.
And
Um,
oh, go ahead, go ahead, go ahead.
I would say, act to minimize your risk by eating a healthy diet. As we talked about, make food your medicine. Losing weight before you're going into a pregnancy. So as I mentioned,
Mm.
women who have a higher BMI have a higher risk of complications in pregnancy. Have an active lifestyle. So staying up to date with your medical care, taking your prenatal vitamins. Actually, if you're planning to get pregnant, you should be taking prenatal vitamins 2 months prior to when you conceive.
Hmm.
Reduce the use of alcohol, tobacco, recreational drug use, and optimize your medical conditions, including your mental health, because people forget about
Hmm.
that.
Hmm.
Um, so if you have high blood pressure, get your blood pressure under control. If you have diabetes, get your blood sugar under control.
Hmm.
Find a doctor that you trust. and ask the hard questions. I think that's the biggest part. It's like you have to have a provider, whether that's a midwife, whether that's a nurse practitioner, whether that's an MD, like an obstetrician, that you can trust and that you feel comfortable with, and that that person takes your concerns seriously. And if you have complications arise, is that doctor or that provider equipped to handle them? And if they're not, do they have someone that they can refer to, like someone like me who's a maternal fetal medicine doctor?
That's right. That's right. Someone
And
like
then
you.
finally, I would say advocate for yourself. As I
Hmm.
say all the time, it is your baby, your body, right?
Hmm.
So never feel like you cannot ask a question for clarification, to
Hmm.
your provider, because this is your health and your baby, and you should feel like you should be able to speak up.
Hmm. There, uh, midwives are on the rise. What are your thoughts on midwives?
I love midwives. So I think, I trained at Case Western in Cleveland, Ohio for residency, and I did my fellowship at Duke University in North Carolina. And we work closely with midwives. And I think midwives are a valuable member of the team, of the delivering team. And so midwives have filled in the gap a lot where obstetricians aren't available. So, in a
Mm.
lot of smaller communities where there are a lack of professionals to take care of, providers to take care of women, midwives have filled in that gap. And so,
Mhm.
midwives are great for low risk pregnancies. I
Mm.
think they have all kinds of tricks to get that baby through the vagina. And so,
Yes.
a low risk pregnancy, midwives are amazing at. Now, when you get to extremely high risk pregnancies, the midwives I work with are very good at like, hey, I need your help. Like this patient is super sick. This is beyond my level of training, and I
Hmm.
need you to come handle this.
Yes.
And so,
Yes.
working side by side, we keep women safe.
Okay. Rest. A lot of times I see a lot of young babies just being born out in the public, no matter what time of year or season. So, is the rest period after delivery still 30 days?
There isn't a specific rest time, I would say, that we talk about, but we do tell women that you need, at least about, like, we see you 6 weeks after you deliver, right? Like 4 to 6 weeks after you deliver, and that is because we are expecting you to be at home resting, right? Your body has to recover. And
That.
so and I think other countries do this better than us. Like South Korea is wonderful about that. A lot of European countries are wonderful about that, giving women time to rest and recover before they
Mhm.
enter back into the workforce. We're not so good at that in this country.
No, right. And is it healthy? Because you're walking in this world and you see newborn babies out there. Is it healthy for newborn babies? Because they used to talk about that soft spot. Back in the days they used to say keep it covered because it causes colic and all those things. So how is that working nowadays? And is it important like this time of the year to have that, because a lot of times you see the parent covered but the child's not covered up and they're arm babies.
Yeah, yeah. Again, I'm not a pediatrician, but I will say, yeah. So the baby's immune system is very immature, which is one of the reasons why certain vaccines we don't give until 2 months of life. And so during that period, babies really should be at home. They really should be, you should really be nesting at home with your baby. You should be limiting the interaction of people interacting with your baby, again, because their immune system is very immature. And so if they catch something or they get sick, it can be devastating or catastrophic for them. And so babies really should be nesting at home with mom and those first
Mhm.
months.
And that's the next question. How should they keep their cells healthy prior to going back in 6 weeks after they delivered?
Again, food is your medicine. Maintaining a healthy diet. Um, getting out there, I would say it depends on if you had a vaginal delivery or C-section. So I had a vaginal delivery with my daughter, and about 2 weeks after delivery, I walked. And it wasn't long, but I would just get outside and walk for about 30 minutes just to kind of she was little, so I would leave the baby at home with the husband, just get out and walk for about 30 minutes, just to kind of get some fresh air, get some sunlight, get my body moving. Um, and then with C-sections, I would say, give yourself about 4 weeks, and then you want to
Mhm.
get out there and start walking. Um, and even as you're recovering at home, the C-section, you got to get up and move.
Mhm.
The more you move, the better you're going to heal.
Mhm.
So you got to get up and you got to move your body.
Mhm. Okay. I have a thought going. Okay. All right. And the no. What are your thoughts on the no abortion law? Where are we at with that?
So that really does impact my field, and
Okay.
I'll talk about that in a little more detail. But I kind of want to give you some data. So after the U.S. Supreme Court overturned Roe versus Wade, so that was in 2022, that Roe versus Wade was overturned. Georgia immediately implemented House Bill 481. And so House Bill 41 prohibits most abortion once a cardiac activity is detected, which is typically around 5 to 6 weeks of pregnancy. And that is before most women even know that they are pregnant, right?
Mm.
That is very restrictive. There are only few exceptions. And so the few exceptions are medical emergencies. So abortion is necessary to prevent the death of a pregnant person or major bodily function from being substantially and irreversibly repaired. So I've had patients like that where I've had to advocate for abortion in the state of Georgia because I'm like, she will die if we don't. Um,
Yes.
if the pregnancy is a result of a rape or incest, but there's a caveat to that. You have to have an official police report um,
Mhm.
that has been filed in order to get an abortion in that situation, and the pregnancy has to be under 22 weeks. Or this impacts my field. So a medically futile pregnancy. So that means an unborn child that has a profound and irredeemable congenital or chromosomal anomaly that is incompatible with sustaining life after birth. And so sometimes I will have moms that have a baby, like one of the classic two ones that I see often are limb body wall defects. So that's where the organs are developing outside of the body. And so the heart's outside of the chest, the stomach is outside of the abdominal cavity. Those babies are not going to survive. So it doesn't make sense for the mom to take on the risk of a pregnancy for a baby that's going to die immediately after birth.
Mm. Mm.
Um, or sometimes I have moms that come to me and I do a scan and there is no skull. So
Mm.
the skull is gone and the brain is eroded because of the amniotic fluid. So this baby has what we call anencephaly. So this child is going to die. And so it doesn't make sense for a mom to carry a pregnancy
Mm.
to term in that situation. Hold on just a second. I'm going to plug up my laptop.
Okay.
Starting to die. Okay. Maybe
Okay.
there we go.
Okay.
So yeah, uh-oh. Okay, there we go. So yeah, so those cases I can get abortion spirit in the state of Georgia in those situations. Now there are other times that I can't. So like say if a mom I had a mom that had a baby, we knew that baby was probably going to die like after
Mm.
delivery, because baby was already in heart failure. She's 20 weeks. The baby had anomaly in the lungs, but I couldn't say that. So it wasn't one of those conditions where I can say it will die.
Right.
But in this situation, I'm like, I know it's going to die, but I can't say that it's going to
Mm.
die. And so I had to send this mom of who has 3 children, right? Who works at MARTA,
Mm.
who has like, where's she going to get the funds from? I had to send her out of the state. So I had to send her up to DC for her pregnancy termination, which
Wow.
was terrible because she had to take time off of work. She had to pay to get up there, and she's already like resource limited. So it definitely impacts my field. And so I did want to share like one story with you, and then also share other stories that I've personally encountered. So
Okay.
I want to speak this woman's name. Amber Thurman, I think it's really important to continue to tell her story. It is a story that Kamala Harris talked about when she came to Georgia for many of her campaign rallies. But in 2002, Amber, she's an African American woman. She had recently moved into a new place. She had a 6-year-old son. She had just applied to nursing school, so she's trying to, improve her life for herself and her child. And then during this time, she learned she was pregnant with twins. Her family said she was worried about how she would care for the twins and her son and finish nursing school. And at that time, that was right when Georgia had just implemented the 6-week abortion ban. There was a lot of confusion about what physicians could do. A lot of physicians were scared about losing their license because everything was so unclear. And so at 9 weeks pregnant, she drove 4 hours to North Carolina to get a surgical abortion, but she missed the appointment due to traffic. So as an alternative, they offered her an FDA-approved abortion pill combination, which we use all the time, right? It's not contraindicated, we use it all the time. So they offered her that as a substitute. So she did that. And days after taking the pill, she experienced cramping and was taken to the hospital where she was diagnosed with an incomplete abortion. So she passed some of the products of conception, but not all of it. And so doctors, because they were all confused and worried about this new law, waited 19 hours before offering her a life-saving DNC. So DNCs are stuff that we do in our sleep. We do them all the time. They waited 19 hours to offer her the life-saving DNC because they didn't know what to do. And unfortunately, by the time they performed the procedure, it was too late. She went into septic shock. So her organs, she was infected from the products of conception. Her organs started to shut down and she died shortly afterwards. Now, that was a death that was preventable, right? And that is all because of Roe versus Wade being overturned. And I can tell you my own, day to day as a maternal fetal medicine doctor, I get called to come to the hospital because a woman breaks her water early. Maybe she's 20 weeks. The water or the amniotic fluid around the baby is vital for fetal lung maturity, right? So if there's no fluid, the baby's lungs are not going to develop. That child is probably going to die after delivery because they have, poorly developed lungs. Or a woman can get infected and get really sick, like the situation with Amber. Or I have situations where a mom goes into labor and her son up early at like 20 weeks, and that baby can't survive outside of her. And oftentimes I have moms look at me and says, there is nothing you can do. There's nothing. So 5 years ago, I would have just augmented the labor. I would have just induced you, let you have the baby. We know the baby's not going to survive, but really it's for your benefit so that we reduce the risk of you bleeding, hemorrhaging. We reduce the risk of infection, like you developing an infection in your uterus, which could actually lead to you having a hysterectomy, which can also lead to you dying, like in the case of Amber. So we would just induce you, or we would do a DNC. And now I can't do anything. And so I have, families all the time saying, you tell me as a doctor, you can't do anything. I can't. I can't.
How did you build up? What did it take for you to build? Now you knew what you wanted to do as a profession. How did you build up your strength to deal with those tragedies of losing a patient or losing a baby during these times? Or if you knew, like you said, that this lady Amber could have been preventable, but by their lack of treatment, it didn't help. So yes.
Prayer. So every morning I wake up, I pray every morning. I pray, I meditate, I read my Bible every morning. I always, say that when I enter the room as a physician, I want God to enter the room before me. And that when the patient, when I interact with the patient, my compassion that I display, I want them to see God in that compassion. And so that's the major driver for me is leading by faith. And, I credit my grandfather for that because the things that I've seen and the things that I've had to do, there's no way I could have the resilience or the strength to get through that without God. And
Mm-hmm.
also knowing that I am not God, right? And so at the end of the day, I always say, not my will, your will be done.
Mm-hmm.
If it is your will, it is your will. But
Mm-hmm.
if if I am here and there's something that you can use my hands or my mind to help in any way, then I'm
Mm-hmm.
here, and use me as a vessel and a tool.
Mm-hmm. Mm-hmm. Let's talk about postpartum. How serious is postpartum? Can it be treated, or does it come back and forth? What's the
What
stages of it, and what's the system? I
What
what's
do you
the
mean by
symptom?
postpartum?
Postpartum, after the woman has the baby, and she says she's not connected to the child.
Mhm.
I think Serena Williams went through that with her second child.
So I guess not. So what do you mean, like postpartum? Are you talking about like
Postpartum depression.
depression? Okay, that's the word we're
I'm
missing.
sorry. So how many? So let's go back then. Um, how many different postpartums are there for me to pull out and say postpartum depression?
Well, so when you say postpartum, that's very generic. So that's just the postpartum period after delivery, which could be, include encompasses anything. So you have to be
Okay.
specific about what you mean. So postpartum depression specifically is a condition. Um,
Mm-hmm.
and so, one, we know that certain women are at risk for postpartum depression, right? So women who have mental health illness
Mm-hmm.
pregnancy, whether they have depression at baseline or they have a history of bipolar disorder or anxiety, etc., those schizophrenia, those women are at very high risk for postpartum depression. And so those are things that we counsel women about throughout the pregnancy. Hey, you're at risk for this. We're monitoring for signs and symptoms of this. When you come in for postpartum, we have you fill out a depression screen or scale. So we're constantly, monitoring for it, because oftentimes we have therapists that we work with that can work closely with those women, and medications that we can use to help treat depression. And then also to women who have, complicated pregnancies or complicated postpartum courses will also be at increased risk of depression, or women who have an adverse fetal outcome, their baby passes away or their baby's like really sick.
Mm-hmm.
Those women are going to have high risk of depression. So we follow them closely and we try to get them connected with a therapist or treat with medication when indicated.
Good question. Okay. Um, what was my next question? Oh, how many black women are in your profession?
Oh gosh, I don't know that statistic off the top of my head. It's got to be less than 10%. Now,
Mm,
MFM is probably less than that.
So you're one of just one. Okay.
One
Okay.
of just a handful. Let me see. So for example, at Duke, so in my maternal fetal medicine fellowship program, I think our fellowship, oh God, I think our fellowship started in the 70s or something like that.
Mm-hmm.
Um, and I think during that time, there's probably, and I could be wrong, so don't quote me on this, but I think there's only been four black women that graduated from fellowship at Duke.
Mm-hmm.
And I know all of them. It's myself and three other women. Oh,
How
we know
many
each other.
how many total years of schooling did you have to get to where you're at now?
Um, so a lot. so, so 4 years of college,
Mm-hmm.
and then most people, when you go to med school, most people just do the MD. So it's just 4 years. I did 3 degrees simultaneously. So I was the first person in Morehouse School of Medicine's history to do 3 degrees simultaneously. So I did a medical degree, a PhD, and a master's of science in clinical research. And so that took 9 years. So 5 years for the master's and the PhD, and then 4 years for medical school. And then after that, it was 4 years of residency and just OBGYN, and then an additional 3 years of fellowship in maternal fetal medicine.
Okay, let's talk about menopause. Can we talk about menopause? Is that any
That's not my
different?
area of expertise.
Oh, Lord.
Yeah,
Okay.
so that will be the gynecologist, right?
Okay.
So the OBGYN, your OBGYN, they
So
would.
so streamline your profession, because you said I couldn't ask you about autism and everything, but just the overall, where does your profession begin and end as far as women's health?
So I'm a maternal fetal medicine doctor. So I take care of high risk pregnancies. I
Mm-hmm.
only deal with pregnancies,
Okay.
and I deal with the sickest of the sick pregnancies.
Mm-hmm.
So
Bless your heart.
I don't do GYN. I don't do menopause. So I'm only, and I don't do contraception. I do pregnancy, just pregnancy.
Okay. Okay. Well, thank you, Dr. Kateena. I do, Canada. Thank you. Good to see you, niece. Good to
Yeah,
see
this
you.
was fun.
Yes. So how did you, so two more questions. How did you balance doing what you do and having two children? And how was your time after delivery to get back up to do what you're doing?
That's a loaded question. Um, it's hard. I have a lot of help.
Okay.
There is no way. So, in fellowship, when I had Zoe, I had a living nanny. So fortunately, I was in a position where I had a husband who is extraordinarily successful. And so when we met when I was towards the end of med school, and so basically he told me my husband's an executive, a supply chain executive, and so basically he told me to focus on education. He took care of everything else. So he paid all the bills, and I never had to worry about anything. So I just focused on school. And when I had Zoe in North Carolina during fellowship, he travels a lot for work, so he wasn't always there. But he hired a live-in nanny. So I had a live-in nanny that was there with me, that was taking care of Zoe when I was in the hospital for godly hours, while I was doing 24-hour calls or working 36 hours straight. Like the nanny was there to help me.
Mm-hmm.
And then I had Grayson after I graduated and was working as a physician. And so I have a live-in nanny today because my husband is a supply chain executive. So a global supply chain executive. So he travels all around the world. So he can be, he's going to China next week and he'll be in China for like 2 weeks.
Mm-hmm.
So he's always constantly traveling. So I have to have someone who lives with me to help. My schedule is
Yes.
crazy.
So
Um,
I asked you a lot of questions that was in my mind about women's health. Is there anything that I didn't ask you that you know that is imperative to share with the listening audience about women's health?
Yeah, so I would say, again, going back to I treat pregnant people, pregnant women. So I would say there are two like key things I'll probably like leave with your audience. I would say um, for all pregnant women, there are 10 things that you should ask your doctor,
Mm,
right? And so I'm going to send you those 10 things.
okay.
So one, you want to ask your doctor, do you take care of high risk patients?
Mm,
Am I high risk? If I'm high risk, why am I high risk?
mm,
Um, and then tell me more about my high risk condition. What is it? What does it entail? How do we manage it? Who is on your team? Do you work with a team of doctors, midwives, nurse practitioners, um, who will care for me? What hospital will I deliver at? Do you need to ever transfer patients to other hospitals? So sometimes you may deliver at a low risk hospital, but if
mm.
there's any complications, they have to transfer you to a tertiary center. Is that close by? Where is that? If I deliver early, will my baby be transferred to another hospital? So, for example, you deliver at a low risk hospital and you have a very preterm baby, they will sometimes have to transfer that baby to a higher level of care facility.
And the mother will be in one place and the baby will be in another
Sometimes that
place.
happens.
Mm.
Sometimes that happens.
Okay.
Um, who should I call at night or on the weekends or after hours if I have a problem? Like, I should
Mm.
have a on-call service. Every obstetrician should have that. How often will I need to see the doctor during my pregnancy? So women who are high risk will have to see the doctor more frequently. And what can I do to improve my pregnancy outcomes? And what signs should I look for? And so that kind of segues to those red flags. And so things that I talk to my pregnant women about are red flags, right? You are high
Mhm.
risk. These are things that you need to be looking out for. So if you have a high risk of preterm delivery, if you're having cramping, so you're cramping every 5 to 10 minutes, you try to rest, you try to hydrate, and it continues for a second hour, you should be calling that your doctor. Um,
Mhm.
if you have any type of bleeding or fluid that keeps coming, like you urinated on yourself, you should be calling your doctor. Those things are not normal. As far as other high risk symptoms, signs and symptoms of preeclampsia. So we kind of talked about earlier when we spoke about Black morbidity mortality, and one of the reasons for that is hypertensive disease in pregnancy, and that is because a lot of women don't know the symptoms.
Mhm.
So that's important that we talk to women about that. So symptoms include, headaches that don't go away with rest, hydration, Tylenol, eating. That headache is still persisting. That's concerning to me. Changes in your vision where it's spotty or blurry.
Mhm.
Chest pain or difficulty breathing. I'm having a hard time breathing. I'm sleeping with a lot of pillows because if I lay flat, I cannot breathe. Or walk I walk up, just 2 stairs and I can't hold a conversation because I am so short of breath. That is not normal. Swelling. So you're going to get swelling as your pregnancy progresses. That's normal, but it goes away. So typically, what happens is you get swelling throughout the day, you lay down at night, you get up in the morning, that swelling is gone. This is swelling that's persistent. So I'll see patients that come in to see me, they have high blood pressure, disease of pregnancy. They're not wearing their rings anymore, right?
Mm.
They're 6 months and they don't have the ring on.
Mhm.
That's a red flag for me because that's a lot of swelling.
Oh,
Or
really?
they're switching out of shoes. Like I'll see some women come in and they have on big flip flops and socks, and I'm like, you can't wear your shoes anymore. No, I can't wear my shoes anymore. Let's check your blood pressure. So all those things are red flags for you need to check your blood pressure. Or pain under your right breast, that's where your liver is located. So any of those symptoms, you need to check your blood pressure. And a number of 140, the top number 140, or that bottom number of 90, any of those, being that high, you rest 5 minutes, you check it again, 140 over 90 is still that high, you got to call because you may have preeclampsia. And making that phone call could probably save your life and your baby's life.
Mm. Mm.
And
Mm.
then the other thing that's important to ask is, to ask your OB provider, am I at risk for preeclampsia? Right? Most Black women are. And so the only thing that we have to reduce that risk of preeclampsia is aspirin. So starting a baby aspirin, 81 milligrams a day, starting at 12 weeks in your pregnancy, reduces your risk of preeclampsia significantly. By some studies, anywhere from 30 to 60%.
Mm. Well, thank you so very much, Dr. Kateena. I do Konadu. That was very good information, and I hope someone out there in the listening audience can use some of the information you gave and can understand better some things that they went through now that you explained it. So, if you ever have anything else to come speak to me about on invitation to a conversation, feel free to come by. Okay?
Yeah, it's my absolute pleasure. Thank you for having me.
Thank you so well. You continue to have a blessed weekend and a blessed new year. I'll talk to you soon.
You too. Bye bye.
Bye bye. How did you like